I am thrilled that Jen Flexman is able to come and present today. She's the co-founder of Minetta Health, and this is a venture-backed health tech startup. And their goal is to make high-quality cognitive care accessible to all older adults. So, incredibly meaningful work. And she's held senior leadership roles in digital health and health innovation at locations such as Babylon Health and Life Labs, Canada's largest private medical laboratory. She has training across both technical and business degrees, so an MBA from the University of Toronto, a PhD in bioengineering from University of Washington, Seattle, and a bachelor's in engineering in electrical engineering from McGill University. Um, we welcome you to put questions into the chat while Jen is giving her presentation, and I'll collect those for asking at the end, and then we'll have some time for open discussion and question asking. So Jen, I'll hand this over to you.
Great, thank you, Jenna. And I will just share my screen here. Um, it is a pleasure to be here with you all, and thank you for the invitation. As David mentioned, I'm a recent completer of the A2 pilot project funded by Mass AITC, and really grateful for the support that we've had. It feels like for years on this project, and just navigating all the NIH intricacies, as well as being able to connect with so many people within the UMass ecosystem has been really great. And I'll be talking about the collaboration in many ways we've had with UMass Amherst over the past few years. So today I am here to talk to you about old school meets new school. You might be wondering, what is old school in this context? Old school is the telephone. It was something that's been around for 150 years and something that most people are familiar with. And I'm going to be explaining how we're taking the telephone and really using it to deliver healthcare in an innovative way that leverages both voice and AI and automation technology. So cognitive impairment is something that is one of the largest yet least treated conditions in aging. An astonishing statistic, I think, is that 1 in 3 older adults over 65 have a diagnosable cognitive impairment, whether that's mild cognitive impairment or dementia, such as Alzheimer's disease. So this is a very prevalent condition, and yet as a society, we are still trying to figure out how to best support people on their aging journey. There's 250 million people affected globally and nearly 20 million in the US alone. And this is also resulting in a huge amount of healthcare expenditure. In the US, the healthcare system spends more than $250 billion on dementia care and cognitive care. And if you factor in the amount of funding and the amount of indirect costs associated with family caregiving, this number can triple. So, this is a huge amount of resources that as a society we are putting towards dementia care. And I think we can do a better job of supporting people along the way. But let's back up a little and think a little bit about what it's like to be experiencing cognitive impairment, especially at the earlier stages of decline. So when we talk to our patients, we hear them say things like, it started with minor things like forgetting where I put my phone. I'm in conversations. I can't remember people's names. That may sound innocuous enough, and some of that, of course, is just natural aging. However, if it's a precursor to dementia or a more severe cognitive condition, then these little signs can have a real impact on people's lives, especially as they start to progress and get more severe. People talk about losing track of time, being unable to complete tasks, being disoriented in daily life. And this is both impacts people's level of confidence in their ability to do things. It also has a really significant impact on their desire and ability to go out and interact socially in the world. And we know now that social interaction, being connected to other people, these are important factors for actually preventing dementia and are also important risk factors associated with the development of cognitive impairment. And so you have this snowball effect where people start to withdraw, and then it gets worse and worse. And so this is a very important time in the cognitive journey where I think we have the opportunity to help people not lose that confidence, to help them feel that they can manage their daily life better, and to then help them stay cognitively functional for a longer period of time. So we believe there's an answer that is hiding in plain sight, if you will. Cognitive rehabilitation therapy has been around for many, many years, for decades. It's a form of behavioral health intervention that helps people, similar to how physio helps people recover through physical disability. It is generally delivered by a qualified therapist, such as a speech therapist or occupational therapist, and it is an individualized therapy that is focused on the individual patient's goals. So if a patient is coming in and talking about not being able to follow conversations or forgetting things, then the program will be designed towards how does that impact your daily life, and how can we get you back to function in terms of those challenges you're experiencing. It's practical and personalized, so it's fundamentally designed to help with the acts of daily life, and it's all about function. We're not here to, change the underlying biology of the disease, but help people actually adapt and control their environment in a way that helps them be more functional. So it really is at the core about empowerment, about the patient as well as the caregiver, who is often integrated into cognitive rehabilitation, and helping them have the tools that they can use in daily life to overcome these challenges, and then feel that they can solve their own problems and help navigate them through the cognitive journey. What does it actually involve, though, in terms of what are people experiencing? Well, there's a number of different components of cognitive rehabilitation that are incorporated into our program. The first is compensatory strategies, and these are techniques and tools that people can learn to help them adapt and accommodate their disability. So this may be as simple as keeping notes or setting timers, helping them with a calendar. It could also be visualization techniques or other things to help them with their memory issues. It includes a component of restorative therapy, which are targeted cognitive exercises focused on areas where there's a deficit. So whether that's a cognitive domain like attention or short-term memory or long-term memory, it helps them practice that exercise under that area of cognitive domain, and then helps them develop and practice cognitive strategies as well as stimulate the brain in those areas. It includes care partner support, so incorporating the caregiver in a very careful way to the program is an important part of it, also empowering them to continue to generalize what the patient is learning in therapy to what's happening in daily life. Because it's the care partner who's there with them often all day, and they can really take the learnings and help their loved one integrate what they're doing into more tasks during the day. It's also about lifestyle education, and this is something that in our particular program we believe strongly needs to be incorporated into a holistic view of cog rehab. What this means is if somebody is struggling from factors like sleep or stress management, the therapist can also incorporate strategies and learning associated with addressing those challenges, because often patients don't realize something like sleep is really impacting their cognitive function. And so if they can address that underlying cause, then they can achieve better improvement over time. So it's really very holistic. The degree to which the program focuses on these different areas is designed by the therapist, and again, is really focused towards how do I help this person get back to function in what matters most to them. So you might be wondering, well, what's the evidence for this? We're all a good number of scientists probably on the call. There's a growing body of evidence that cognitive rehab is a extremely effective tool to use with patients who are experiencing dementia or early cognitive decline. There was a Cochrane systematic review in 2023 that looked at the entire literature and concluded that inclusion in post-diagnostic care was justified, and that it should be an important part of the clinical toolkit in helping people overcome everyday barriers imposed by these cognitive challenges. What does that translate to? Individual studies have shown that cognitive rehab can significantly improve functional abilities in everyday life. Importantly, it reduces caregiver burden in allowing the caregiver to play a greater role in managing what is happening and coping with the changes that are happening at home. And in one study, they actually showed that they could delay institutional care for 6 months as a result of these factors, which not only has an impact on quality of life, but also has a significant financial impact on families that are often unable to pay the cost of institutional care. However, even though in the US, Medicare actually covers cognitive rehabilitation with a qualifying, clinical justification, the access to this therapy is very limited in outpatient settings. And the reason is because it's primarily delivered today in person, and where you find it most often will be in senior care homes or institutional settings where therapists are already present and are already working with patients on other issues. However, that means that patients living at home in outpatient settings, and particularly those who are living far from, big medical centers and rural communities, really don't have access to in-person care. It's just not practically feasible. There's also a therapist shortage. So there's a growing demand for therapists, as we all know. And in particular, given the amount of people who are growing every year in our aging population, there just aren't enough therapists to address the future demand that's going to be required for cognitive impairment. And last but not least, low awareness and stigma plays an important role. Often the treating clinicians, MDs, NPs, even neurology clinics are often unaware that cognitive rehabilitation is an effective form of behavioral care and a treatment pathway for individuals living with cognitive impairment and early dementia. And especially they may not see the value or know that it's available to people at the earlier stages, such as MCI. And so you have this gap where often patients are finding or getting a diagnosis, and then they're really not being given many options after that. And so if they do find anything, it's often on their own. So we are trying to address all of these components in order to make cognitive rehabilitation more accessible, and especially to reach people earlier in their cognitive journey so that we can intervene at milder stages. So we are redesigning the model of delivery for an existing intervention, cognitive rehab, and we're doing it by bringing together voice AI, the telephone, and automation. And I'll be explaining more about why each of those components is important to achieving greater accessibility and also being able to scale this to more people. We're essentially breaking down the four walls of the clinic to be able to bring this into people's homes. So really reaching people in outpatient settings, but also doing that in a way that allows all communities to participate, not just those who are in proximity to a specialized medical center. We're doing that, as I mentioned, through a familiar interface, the telephone, and we did that very deliberately in working directly with our patients and getting feedback. In fact, we tested out different models of delivery, and it was the telephone that was really the simplest. No passwords, no apps. You don't have any barriers associated with technology literacy, and it is the most preferred communication modality of older adults. So we're meeting people where they are, where they're comfortable, and where there's no issues. We've worked with rural health systems who said, my patients, they don't even have stable internet. So even if you had a simple way to do it over an app, they wouldn't be able to access it all the time. And so we also don't want to create any issues in terms of, rural communities not being able to use the delivery mechanism. To address the scale question and allow one therapist to reach more patients, we're building a model that uses AI-powered sessions on demand. And this is where I'll be spending more time in the talk to talk about how we're actually scaling an automated component of the therapy delivery that uses automation to deliver cognitive exercises to patients. And finally, remote clinician oversight is critical in our model. We are not removing the clinician from the program, but rather we're giving them new tools and new ways of working with patients that allow them to do their job more effectively and have complete oversight over care. So this is really, we think, an augmentation of the role of the clinician, and having the clinician at the core of both the design of the program as well as when we deliver it is an important principle that we hold very dearly. So what does the clinical workflow look like if you were going to participate in cognitive rehab with Moneta? We are forming partnerships with different clinics, neurology centers, health systems, where we can become a referral pathway for patients who are identified through screening or diagnosis in those settings. So often the MD or the NP is identifying a patient who might be a good candidate. and then is sending us a referral either through an Epic integration or good old school eFax or however that works for them. We're then checking to make sure the program is the right fit for them, doing some basic screening, but really we're trying to get them matched up with a skilled speech language pathologist who will spend a good hour with them over the phone, doing a comprehensive cognitive assessment, as well as understanding their goals, their needs, their life context. The caregiver is a part of this conversation so that they can share their perspective. And really the goal of this session is to be able to understand the patient and then design a care plan that will be personalized and address the goals that that patient has for daily function. Then the patient starts to go through the intensive therapy portion of the program, which is about 1 to 4 months. On average, patients complete about 2.5 months in the program. That period of time, by the way, is limited in part by Medicare reimbursement, so we can talk about that a little bit more. Medicare does not pay for this indefinitely, and also patients should not do cog rehab indefinitely, but they should do it as long as they're making progress and as long as they're willing to participate in the program. During that intensive therapy portion of the treatment, they are both meeting with their therapist over the phone on a weekly basis, as well as completing automated cognitive activities through our automated AI assistant. And I'll talk more about what that's like. And during this time, we're also generating clinical documentation, we're generating progress reports, and we're sending that back to our clinical partner. And that's important. I know that sounds very bureaucratic, but we really see this as an integrated part of what patients are receiving in terms of care. And we want to make sure that the patient's care home is still in the loop in terms of what we're doing. Often the information that we can generate in terms of the context of the patient and what's going on is really valuable to the care team because we can spend more time talking to the patient about all these things and really provide that back to them in a succinct way in terms of informing the rest of their care. And then finally, once they finish therapy, they can move into a maintenance phase where we want them to continue to maintain the progress that they made during therapy in terms of meeting those goals. And they can continue to check in with us and us with them to see if things are changing. If a patient is experiencing a new set of challenges or further cognitive decline that warrants re-entry into therapy, we can do that, and Medicare will reimburse for treatment within a certain amount of funding each year. So we also see the opportunity to work with people, not just one and done, but really work with them over the long term and over multiple years as unfortunately many conditions are progressive in this scenario, and really helping them cope over time as well. So we want to see ourselves as a long-term partner with the individual and their family. So now I'll shift gears and talk a little bit about what the platform is that we've built and how we're bringing technology into the delivery of cog rehab. So before I talk about our platform, I'll explain what happens today in today's world. Typically, a patient and a therapist are coming together in person. The therapist is delivering a series of activities that might be pulled out of a workbook or on a sheet of paper. They're working with the patient to ask them questions or test their short-term memory, ask them, give them stimulus and see what they're saying back, and then recording that and giving feedback and coaching along the way. One of our insights was that this is a very structured activity. The activities that they're doing with patients are pre-written, and they're very structured in terms of the questions and answers. And it's taking the clinician a long time to do this. They're spending time just asking questions off a sheet of paper. And so we had the insight, working with our team of speech therapists, that we could convert that into an automated portion of the therapy program while still maintaining the therapist's role in the delivery of therapy. So what we're doing is using AI and automation, but in the voice context, to be able to automate the portion of therapy that is composed of cognitive activities. These activities, again, are exercises associated with short-term memory. It might be listening to a passage and then answering a series of questions about that passage. And that allows the patient to both stimulate the areas of the brain that are associated with their deficits, as well as practice their cognitive strategies. And so the way that we deliver that, we've built an entire software platform as well as voice delivery system, is that the therapist accesses the software platform through a web portal, and they're able to program the content that they want for that particular patient, drawing on our library of audio-based cognitive activities. We have literally hundreds of activities at this point, and these have all been clinically validated and vetted by our licensed speech therapy team. So the therapist is setting up the content and preparing what they want that patient to receive based on their cognitive assessment. And then our AI-powered digital therapy assistant is what is actually calling out to the patient. The patient simply receives a phone call, answers that phone call, and then hears a voice and goes through a series of interactive question and answer activities. They're answering these questions out loud, and these sessions are being recorded so that the therapist can then review those after the fact. And then when they meet with them on a weekly basis, which is an important part of the program as well, they're able to give them feedback on what they heard in those calls and coach them on what's happening, as well as take all of that information and adapt the program to create new activities for the following week. So the program, the content is continuously evolving, and it's really driven by this clinician oversight, but the delivery component is being done through automation. Now, why is this better? Well, the patient, for one, can access these cognitive activities and go through this process at any time they want. So they're setting a schedule, generally 3 times a week, that works for them. Often when you're doing face-to-face therapy, you have to meet the therapist when they're available. And that might not be the best time for the patient. It might be in the morning when that is not the best cognitive time for the patient. And so this allows them to really do it when they feel that they're at their best. The other component is that they can do it as many times as they want. This is automation. So they can also call in a toll-free number and do their exercises repeatedly. They can do them every day. They can do them multiple times a day. And I'll talk a bit about what behaviors we actually see when we give patients these options. So really what you're doing here is you're increasing the intensity of care that you can deliver through CROG rehab instead of being limited by a therapist's schedule and by the physical transportation of individuals to the same place. We can now deliver cognitive exercises at a much greater frequency, and that has benefits in terms of being able to drive better clinical outcomes, as I'll talk about in a second. So now I'll pause and I'm going to show you a video. This video was shot in Montana with one of our partners, the Benefits Health System. And you're going to hear from patients as well as some of our partner clinicians in terms of their experience with Minetta and also their own personal stories of struggling with cognitive impairment. So hopefully the audio will come through okay on this.
I remember when I was a teacher, I would have over 100 students per semester, and my goal was to learn every name the first week, and I could do that. And now names have been a really hard struggle for me.
I went to a neurologist at my wife's, I won't say insistence, but encouragement. And I was diagnosed with mild cognitive impairment. He said, well, okay, here's some pills, take these, see you in 6 months. I'm like, that's it?
Biggest thing that changed after my stroke was I couldn't remember things that I had always remembered. Somebody would pick me up and we'd be going to a doctor's appointment or something, and they'd say, do you want to go buy groceries? And I'd go, I don't know what I need.
It's been an interesting process going from working for the hospital to being a patient. When I got this diagnosis, it kind of hit like a freight train at first. It felt like a death sentence.
When I first heard about Monetta's cognitive rehab program, I was initially skeptical. Over the phone, is this really going to be beneficial to the patient? Then I started getting feedback from the patients, and they really enjoyed it.
Cognitive rehabilitation was totally new to me. I first came across Minetta by my nurse practitioner. And I thought, okay, this has got to be good, because when you respect someone and they suggest something to you, it's so easy to go, okay, I'll try it.
I'm Dr. Michelle Marler. I'm a family physician. I've been taking care of patients for 30 years. As far as the brain goes, a lot of concerns with memory. A lot of times I'll pick up on it just with a routine screening. And if it's low, then we have the conversation. How's your memory? How's your thinking? What's your cognition, executive function? And sometimes then they'll open up.
I was very skeptical at first because I didn't know anything about it. Then as soon as I got started, I was looking forward to the calls. Well, the calls are obviously have been designed to be therapeutic, but they didn't feel therapeutic. They felt conversational. She explained it very clearly and very thoroughly, what we would be doing and how we would be doing it. And I really felt like somebody was listening, but at the same time, identifying where they could help me.
When I first heard about the Moneta program, I was thrilled to be able to offer something to people that would give them a benefit. I explained the Moneta program to them as they get phone calls at home, they can schedule it on their own time.
Having that option of being based over the phone has been very beneficial for a lot of patients.
I didn't have to go into an office. I didn't have to go to some place that I would be a little uncomfortable.
To me, part of any healthcare is having the patient feel positive about the direction they're going.
Just yesterday, I went to an exercise class and there was a lady there and I looked across the room. I knew exactly who she was. I knew everything I knew about her. And she came over and we were chatting and I said, Jane, and then I said her last name. And it was like, this is so cool because I remembered.
Well, what Moneta really means to me is that yes, it's been wonderful for my memory, but it has taken my life at a different level. It really has raised my awareness of how people can and should be treated in healthcare and how impactful that can be.
All right. So I hope you heard in that video. I mean, these are real patients who went through our program and real clinicians that we're working with. There's an initial skepticism and there really is a lack of awareness of what cognitive rehabilitation is and what it can do, both on the clinician side and on the patient side. And so I know we're going to talk a little bit more about commercialization, but I think an important lesson that we've learned over time is that we have to really come in and help design these care pathways almost net new, because it's not like there's an existing, routine of referring patients out for this. We really have to come in and educate, and we have to also demonstrate impact. And I think where we're succeeding is really where we can also show that we are delivering a level of compassionate care to patients, and they're coming back and telling their referring physician that this is really helping them and that they feel seen and heard. So it sounds a little bit cheesy, but I think, sometimes in the commercial world, we forget that really this comes down to people and convincing them that you're doing something of value and really helping them in a meaningful way for their life. So in terms of showing value, an important part of that is also showing real clinical outcomes. And although there's a lot of research been done and a lot of an evidence base for cognitive rehabilitation, we believe strongly that we still have to show that we can deliver at least as good care as what you're getting in person. And we have an obligation to monitor and report on our quality metrics, both because we're innovating and reimagining the way this is being delivered. It's a fundamentally different delivery system. And also because we want to learn from this and also incorporate that back so we can understand what's working well. So we look at clinical outcomes through two key metrics that I'm going to talk more about in terms of our impact. And we're really trying to align our metrics with standardized instruments that people understand in the clinical community, as well as benchmarks and the most established benchmarks that we can use in the field that we operate in, which is speech therapy. So the first metric that we use is to assess well-being and quality of life. We use the NeuroQOL, which is an established instrument for assessing physical, mental, and social domains for adults in terms of quality of life, specifically in neurological conditions. It's a very short survey that we do both at the beginning and at the end of therapy. And this is patient reported. So this is patients telling us what they're experiencing. And we're trying to measure changes in that over time. And then the other one that we're using is to assess the cognitive functional change over the course of therapy. This is really our North Star metric, which is based on a functional communication measure. These are a lot of words, but this is what speech therapists use as a way to benchmark themselves against the national database for speech therapy. So we're fortunate in that the American Speech Language Hearing Association maintains a database of self-reported from clinicians data around these FCMs. And so by collecting the same metric and be participating in that program, we're able to benchmark our data against what's happening at a national level. So I'll talk a bit about that because that's how we benchmark our quality over time. And what we're seeing in terms of real world results, so this is what we're seeing with Medicare patients referred to us through our clinical partnerships. This data has been compiled for 141 patients that we have treated and have pre and post data. Our patient profile, and this is very representative of patients coming through our program, is on average age of 71 plus or minus 11. So, these are patients that have quite a wide age range, but are generally on the younger side of older adults. MoCA scores of 20 plus or minus 5. So generally people are in the mild to moderate cognitive impairment domain. About 60% of our patients have an MCI diagnosis and 33% have a dementia diagnosis, although as we all know, ICD-10 coding is very inconsistent, and so we don't put a lot of weight into the actual ICD-10 diagnosis. We really look at our own assessment of their cognition. And when we look at this patient population, what we see are significant improvements across our two North Star metrics. So we see an 18% improvement on average in cognitive function as measured by this FCM. So I know that number is probably hard to digest because most people are not familiar with the FCMs, but to give you a comparison, when we look at the national database, the average across the country for clinicians delivering cognitive therapy of this type, cognitive rehab, is 13%. So we're showing that we're nearly 50% better in terms of our improvement across this metric. And this is something that we check in on frequently to see how our quality is measuring up. In terms of quality of life, we're seeing a significant improvement in quality of life over the course of the program of 11%. And of course, ultimately, this needs to be, gauged against a control population. But we have been measuring this over the course of years, 3 to 4 years, and we have seen this number stay very, very consistent. So although that, there's still more research that needs to be done, we generally see a very consistent improvement in quality of life metric. We also do surveys with patients at the end of therapy to rate their satisfaction, and our average satisfaction score is 4.8. We have an 82% retention to discharge, meaning most patients, the vast majority, are continuing to discharge in the program, and we consider that also a very key metric to show whether patients see the value in this. And so the retention rate here is much higher than typical programs, especially in digital health. And so we look at this very carefully and monitor it to make sure that we're maintaining that. One thing that we're excited to show is the level of engagement with our automated AI voice assistant. So our voice assistant is the component of the program where they were doing the automated exercises on their own over the telephone. And, we didn't know whether patients would engage with this type of thing, honestly, when we started this. And our clinicians were also not sure. And so we wanted to monitor, do people actually participate in these automated calls? It's a very different experience than anything else they've typically done in healthcare. And we recommend that they do 3 calls a week. So we wanted to see, are they actually doing 3 calls a week? Surprisingly, they're very compliant with this program, and they're doing on average 2.7 calls a week, which is almost perfectly compliant with our recommendation. And honestly, we believe that comes from the fact that there is a therapist there who is checking in on them. They know that somebody is listening to those calls, and they are actively engaging with their therapist each week to discuss their progress. It's also because they see the value, and some of these activities, I should say, are genuinely fun for them to do. Our therapists will generate content that is relevant to their life. They'll make it funny. We have a murder mystery series that has to do with memory that people love. And so this isn't just about, something dry and boring. This is also a way to pull people into the interaction and really have them engage with the platform in a way that feels natural and fun. 50% of our patients complete more than 8 weeks in the program, meaning they also see the value over time. So they, if they don't want to continue, they can drop out or they can request discharge. And so we see a very good length of time in the program. And we see that 17% actually exceed the recommendation of 3 calls per week, meaning they're calling in now at this point because we set up a schedule to call out 3 times a week. We call these our super users. These are people who are calling into the system maybe daily to get extra practice and really see the value of doing that. So this was an important assessment of engagement with the digital component of our program, and something that we're excited to be presenting actually at the Alzheimer's Disease International Conference later in April. So if you're at the conference, come say hi. And this is something we also monitor carefully to make sure that we're seeing the right level of engagement in the program, because this is key to generating the right clinical outcomes. Now we'll switch gears and talk about our A2 pilot project. So in terms of how that fits into our overall platform and what we were doing to develop the platform under that project. We're again super grateful to have the support of Mass AITC and the National Institute on Aging. This project was done with myself as co-PI, as well as Dr. Michael Busa at the University of Massachusetts Amherst and his team, and with our lead data scientist, Alexis Yelton. And so what our goals with this project were to take all of the speech data that we had recorded throughout the history of our program. So we had hundreds of hours of speech data, de-identify that and use that to develop AI models that could automatically analyze elements of the patient's speech to be able to streamline the workflow for clinicians. So one thing that we didn't want to do was just take this model, generate a ton of extra work for our clinicians, and now they have to review, hours and hours every week of recorded sessions. We really need to make that more streamlined so that they get the essential information out of it and they can give feedback to the patient and work with them, spend more of their time in direct face-to-face patient care. And then we had a phase of the project where we did a clinical study where we collected additional data in order to validate those models in a representative real-world population, and also wanted to look at were there any model reliability issues in specific subpopulations. So the way we did this, as I mentioned, we record a lot of speech. We did this all on text. So the first thing we did was transcribe audio into text. We then did some data prep in terms of segmenting out those transcripts into the relevant subcomponents, questions, answers, different types of breakdown of those transcripts and what was happening in the call. And then we focused in on a couple of key areas that with our clinicians, we determined were really helpful to them in terms of being able to accelerate and streamline their workflow. So one of those was, did the patient answer the question correctly? We're asking them a lot of questions that have to do with memory, about remembering things in a passage. And so clinicians spend a lot of time scoring and trying to assess, like, is the patient improving over time? How is their accuracy? Are these too hard? These questions too hard or too easy? So the first thing was just, can we score that automatically? And then we also wanted to give them some signals about patient engagement and sentiment, such as, were they not answering questions? What were some of the expressions or verbalized sentiments that were being made on the call? Because they want to know if somebody's frustrated or super engaged. All of that comes into the feedback component. We also wanted to make sure we were understanding any comments about hearing. A lot of our patients have hearing impairment. They're often functional, they have hearing aids, but we also want to make sure there's nothing being flagged in a call that they're saying. And then we collect a series of verbal survey responses that we also wanted to automatically analyze and present to the clinician. So all in all, this was to generate relevant practical clinical analysis that we could then give to our clinicians, and then they can use that in their skilled interpretation of what's going on. And we did this modeling using LLMs with fine-tuning that was then evaluated with expert labeling. So we had our team of speech-language pathologists annotate the correct answer. And we were fortunate enough to have, we work with a great team, and they were able to do that for us so that we could validate the accuracy of the models. So I'll give you just a sort of a high level summary of some of the results we were able to generate using these LLM based models. And fortunately, we were able to achieve the model accuracy levels that we had set out to achieve. And model performance notably was higher than our interclinician variability, which was also something we wanted to benchmark. And so you can see in terms of being able to assess that a patient answered these questions correctly for synonyms, antonyms, and auditory comprehension questions, we were able to achieve between 85 and 90%. And our overall clinician variability, when we looked at multiple clinicians, evaluating the accuracy, that ranged from 14 to 19%, depending on the type of question. So that shows us that these models are in fact meeting a clinical standard for deployment, which was the objective of the project, and that we were able to do this using actually a lot of the advancements in LLMs that happened throughout the project. In fact, we were able to upgrade our models as these came out during the course of the A2 project. And we also wanted to look at different subgroups to see if there was a model degradation or any areas where there were performance issues across populations that there may be a reason to think that could impact the model performance. So we looked at certain demographic information as well as cognitive status information that would be predictive of maybe, a change in the way the model would work with that type of speech. Now we had a very small data set, so this requires ongoing monitoring, but we showed when we looked at this no statistical differences between these subgroups in terms of model performance. So encouraging, but it's also a small data set that we need to continue to evaluate. And then in terms of sentiment and behavioral analysis, we wanted to use this to generate patient insights and give information to the clinician to be able to understand some parameters about the call so that they could then address these with the patient. And in terms of some of the areas we looked at, these were, are patients responding? Were they making comments about hearing? Were they showing signs of confusion or uncertainty? Are they upset? Are they engaged? All of these things can help the clinician guide the conversation with the patient. And what we found in terms of analyzing these within the data set that we had, which was 350 de-identified patient call transcripts, that patients are very engaged overall in our question and answer activities. There is expression of confusion and uncertainty. Some of that is normal. These questions can be very hard, and patients can have, they can be unsure of how they're doing. But it's important that the therapist knows that and can then talk to the patient about that experience and what they were feeling at the time, and then make adjustments as needed to the following week. So these are again relevant and practical tools that the therapist can use in the delivery of therapy that makes them more efficient and more effective. And then in terms of what's next, and I can talk here a little bit about our commercial model and how we're looking to build the company overall and scale it. So we are currently operating in 5 different states. We are a telehealth practice, and we are working in partnership with health systems, neurology clinics, primary care, with the goal of becoming an integrated part of their referral network and an integrated part of their care team. So we spend a lot of time, talking to clinicians and getting them on side or, giving them the evidence that this is a viable pathway for their patients. And then we're also, working with them to show them that we can do a great job with their patients. We are working under traditional Medicare, so we bill fee codes associated with speech therapies. Cognitive rehabilitation, as I mentioned, is a reimbursed therapeutic intervention today in the US. We did not have to go and get new fee codes for that. However, we do not get paid to do the digital component of our program. And so our goal there is really to integrate it into the overall business model. But ideally, it would be better economically, obviously, if we could get paid for that component of the program. We are fortunate that during COVID, the fee codes opened up for telehealth, and in particular for audio-only telehealth for speech therapy. The telehealth extensions are, of course, always a source of uncertainty in terms of political renewal, but right now they have been renewed for the next 2 years. So we're fortunate, and we're confident that they will stick around. I think there's a lot of value in general to the healthcare system. We also contract not only with traditional Medicare, but also with private insurers as a telehealth clinic. And so we have a number of contracts in place in different states that allow us to bill insurance directly on behalf of our patients for these services. We generally do not work with a lot of patients in a private pay model, although we can do that. But typically it's not something people are paying for, and most people have some sort of coverage under Medicare. So with that, I will wrap it up and welcome any questions you have about the program, our data, our results, our A2 project, or about our commercial model. So thank you again for the opportunity to share.
Thank you so much, Jen. I have many questions I could ask, so I'll ask one while people are thinking of theirs. One of the key questions that I had is from a layperson standpoint, when I hear the word rehabilitation, I associate that with an acute event has happened. Someone is going through rehabilitation, and there's an endpoint to that. So if the first time I heard cognitive rehabilitation, I thought of someone who had a TBI or a stroke or a concussion or whatever, and they're going through cognitive rehabilitation. Your care pathway doesn't line up with my mental model of what I think about as rehabilitation. And I don't know if you've come across that like friction when you're talking to people about what your program is versus what people might think about as rehabilitation.
Yes, and well, I recommend actually that so I think this year or the World Health Organization has identified rehabilitation in dementia as their focus. Like, and that it's not just cognitive rehabilitation, but all rehabilitation. So I think this is often a point of confusion in terms of, rehab, thinking about it as something happens and you're bringing them back to the level that they were before, and then we all move on. And I think the field of rehabilitation is actually evolving to be more continuous, right? You see a lot of prehab, post-hab, all of that. In this case, and actually speech therapists fought for this, I think, for many years, was the idea that maintaining somebody's function is actually a completely good outcome in a situation where you have a degenerative condition. So dementia or Alzheimer's disease, there's no expectation that you are necessarily going to come back to the original level of function. But if you can slow the deterioration of function for over time, that has huge value. And so often it's about maintenance as much as it's about improvement. Although with our patients, we do see improvement in targeted areas. So I guess you can think of it more on a continuum. I do think that the way Medicare funds it is definitely on more of an episode of care, though. So, I mean, we're still in a business model where it is not like you're going to do cognitive rehabilitation forever all the time. However, as your situation changes or as there's fundamentally new issues that justify clinically reentry into rehab, somebody can come back and restart a series of sessions.
Perfect. So I'm going to ask a question from the chat, and then Laura, I see your hand was raised next, so I'll go to you after this. But there's a question in the chat about what you can envision about future features. So language features. I was thinking as you said this, like I really like your thoughtfulness around modality now. Is there a time when you think you might have to have sort of a heads up about changing modalities or offering other ones? So just thinking futuristically about how the platform might adapt in new features. If you can speak to that.
Yeah, for sure. I mean, and there's a lot of opportunity to do that. So I didn't go into too many details on our maintenance program, but you can imagine after therapy, a lot of patients don't want to give up the activities. I mean, they certain ones they really value and they want to continue to engage in. And they also there's an emotional journey of kind of feeling like now you're on your own and you've just spent all these months with your therapist. And so, we're really looking at ways that we can support people ongoing after that sort of intensive Medicare version of the program is complete. And that could happen through a number of different modalities. One thing I'll mention, although telephone is great and it's really the way that we're able to engage with people primarily, text messaging is also a great way to communicate with people. And for certain types of interactions, it's better. So we actually do a fair amount of text messaging as well, more logistically throughout the program, but we do see the value in other modalities and ultimately combining them in a way that delivers the right patient experience and the right, communication at the right time.
Perfect. Laura, do you want to ask your question?
Yes, thank you very much. I was noticing, Jennifer, that your success metrics for the patient are involved with self-reporting. People often will have their own motivations. I'm wondering if you have included talking to family caregivers or other people around the individual as a validation for the kind of responses you're getting from the patients themselves.
Yeah, very relevant to the NeuroQOL in particular, which is a patient-reported metric, and often is done by a third-party reporter like a caregiver. So completely, we work with generally with individuals who are reliable reporters, I would say, but that doesn't, in an ideal world, yes, we would actually have caregivers and other people reporting. I would say this is actually a limitation of the telephone. So you can imagine when you're on the phone and you have the caregiver on the phone, it can be awkward or hard to get a third party reporter without setting up a whole separate call. And sometimes that's just not practically feasible. Our therapists have actually noted that in physical practice, like if you're in person, what you would typically do is sort of step to the side, pull the caregiver, over and have a little conversation, and they can't do that. So I mean, there are limitations to doing it this way, and I would say actually that is one. We have talked about, though, are there ways we could do it digitally? Are there other things we could do to incorporate a third-party reporter or a caregiver reporter? So it's a very valid question. And I think if we did a full clinical study, where we had more resources to kind of make that happen. But, we're also trying to minimize touch points, and it's always a trade-off, like to make this not a burden on the family.
And of course, cost is always there.
Yes, yes. I mean, time, we do a lot of phone calls, so generally we're trying not to add more phone calls to the patient schedule.
Thank you.
No, thanks so much. So another question in the chat says that you mentioned that you convert audio data to text and use only transcriptions for assessment. And wondering if you had insights into nonverbal audio cues or nonverbal cues that are important to clinicians that might be getting lost in this.
Yes. That is a really also valid question. I think there's a ton of data in audio that you lose when you simply transcribe to text. And a lot of that is, emotion in the voice. You can do a lot in terms of sentiment that you are getting through an audio signal that you're not going to get in a transcription in text. We're often reliant on words that they're saying rather than the way they are saying it. Now, when we transcribe, we do have an information about time stamping, and like we can see sort of like how they're speaking. There's still some information about that. The reason we're doing it is more practically speaking, it's a way to more effectively compute all of these things, and has some well-established tools for transcription. But I think there's a lot of opportunity to look at audio as well. One thing I'll mention that goes beyond practical is also privacy. So when we are building these models, we are de-identifying text, and we are able to, we do this all manually, like confidently say that these are de-identified data sets. When we're working with audio can just fundamentally not be de-identified because audio is a signature. So that's also a reason it makes the data handling a lot easier when we use text. But, putting my research hat on, yeah, there's probably so much interesting information that you could pull out of the audio that would be really, really interesting to look at.
No, thanks so much. So what, at this point, another question from someone is, what would exclude someone from being able to use your service? So they have cognitive impairment, insurance would pay for it, but what would be some things that would exclude them from being able to use this platform?
Yes. And you know what, before I answer that question, I forgot on the last question, I would like to add, we provide access to all the core raw audio files to our clinicians, so that if they do want to like even sample the audio, they always have the ability to go back and listen to audio, even though we're transcribing and analyzing the text. So that's also an important principle behind just making this safe and allowing the clinician to have as much access as possible to the raw data. But your question now about who would be excluded from this, assuming insurance and referral are all sorted out. So one of the things we do right up front with the patient, we have an initial call where we explain what the program is, and we also do a quick assessment of a few things to make sure that they can participate. So one of them is just general functional ability to operate a telephone and participate in a call independently. So we generally work with individuals from mild to moderate cognitive impairment. Once it's more severe or they don't have the ability to really function on their own independently enough, it's not really an appropriate program for them. And in fact, they're probably better served through in-person care or some other sort of combination of behavioral health. And so we would then refer the patient back to the provider or try to find that option for them. Often our partners may have that option as well in-house. Another reason is English fluency. So right now we only offer our service in English just because our therapists are English speaking and our program has been designed and built that way. However, we do hope to expand that to other languages in the future. And we have worked with a lot of people who English is not their first language. Certainly that's not a requirement. It's just that they have to be able to understand enough of what the therapist is saying to be able to participate. And then hearing levels are important. Probably the majority of our audience, our patient population has some sort of hearing impairment. So what we do is assess functional hearing levels. In other words, do they have a level of function with hearing that meets the ability to hear over the telephone and then respond appropriately? Because what we don't want is to put people through activities where they're not responding correctly, but it's because they can't hear, not because they're not able to remember or complete the exercise. And that is very frustrating for people, which is also why we're trying to monitor that over time. And so we do a little screen to assess functional hearing levels, and the therapist is always attuned to that throughout the program as well. The other big thing that we work with our referring partners on is the sort of underlying clinical status of the patient. So if they have had a recent cardiovascular incident, stroke, there's generally good therapy practices are that they have to stabilize the patient and then we can work with them after about 3 months. So the clinician, we will do the screening as well, and our therapists will make sure that this is appropriate, but we generally want patients that aren't going through other things and actually would benefit from in-person care first before they kind of move over to what we're doing. So these are not black and white sort of criteria because we really want to work with our referring provider as well to find the right mix. And if they have no other options, like if there's nothing else that they can access, then we will try to, accommodate that as much as possible too.
Perfect. And I have one final question. If you have, a 20-second response for someone's asked about if you're measuring any other outcomes related to like social isolation or loneliness that might be byproducts of doing this that are not directly the reason for doing it. Have you thought about that?
Yes, and actually we are a participant in a grant funded program that is focused on older adults living alone. So we see our program actually having a very nice fit with people in that scenario because they may not have people who can take them to visits. They may be more socially isolated. Now, in terms of how we're measuring outcomes, we don't currently measure an outcome associated with loneliness or isolation specifically, but we are actually tracking their living environment and we are through quality of life, you can pick up on a little bit of this too. So we wouldn't be able to show a change in that, but we are assessing, what percentage of our population actually falls into each of these categories because we hope to work with groups in the future where we could do more research on that.
Perfect. I really want to thank you for coming today and talking with us and just doing really meaningful work.
Thank you all for having me.